Hi, this is Mrs. Hauk. This podcast is on chest tubes. Before we go any further, I just want to point out this picture here. These are all chest tube drainage collection systems shown in this picture. They will vary from facility to facility which ones they want to use. It's all different manufacturers, Pleurovac, Atrium. I would say in this area, I've only done clinical at Hershey and UPMC, and I know that this is the one they use. So just to be aware that you may see different drainage collection systems, but they're all set up in the same fashion with the 3-bottle system, and they all work in the same way. So what is a chest tube? Basically, it's a drain placed in the pleural space to restore intrapleural pressure and allow re-expansion of the lung. So the pleural space, as a review, sits between the visceral pleura and the parietal pleura. This is where fluid, blood, air can collect, especially air if there's a hole in the lung, such as a pneumothorax that allows air, or maybe an opening to the chest wall from the outside from the result of some kind of trauma that allows air to come into this space. When air and fluid are in this space, it limits the lungs' ability to expand. What this also does is prevent air and fluid from returning to the chest. There is a one-way valve system in the drainage collection system that prevents this from occurring. Where is the chest tube placed? It depends on the reason for the tube and what it's draining. Air is lighter than fluid or blood, so you're going to see a chest tube placed a little higher if it's solely just for a pneumothorax air situation. Another type of tube that you're going to encounter is a mediastinal tube. This sits in the mediastinal space and drains blood and fluid from around the heart. You're commonly going to see this in cardiac surgery or if a patient has a pericardial effusion that needs drained. These are just pictures to depict where a chest tube could sit for blood or air, and then a picture to show you this visceral pleura and this parietal pleura and the space in between. Every year I look for different pictures of mediastinal chest tubes. I never get better than this, so I apologize, this isn't the best picture, but you can see how the chest tube just lays in that mediastinal space to drain the fluid from around the heart. So conditions that we treat with a chest tube: a pneumothorax, when air gets in that pleural space and we need to get rid of the air and re-expand the lung; a pleural effusion, when fluid collects; empyema, sometimes after infection, pus can accumulate in that pleural space; a chylothorax, you don't hear, this is a rarely heard term, but it can happen if there's lymphatic fluid in that space; after cardiac surgery, as I discussed before, or after some type of lung surgery, whether it be a thoracotomy or a VATS procedure. They can be done for either trauma-related issues or cancer. Some surgeries done for cancer: wedge resection, they remove a small portion of localized area; lobectomy, they take a whole lobe; and pneumonectomy is removal of the entire lung, including all blood vessels. I have this starred for a reason, and I'll tell you in a minute. Just some pictures. Pleural effusion, this is what it looks like when fluid develops and you can see the lung cannot fully expand. Wedge resection just shows you they take a small spot where the nodule or suspected area is removed. Lobectomy, they take the whole lobe. And pneumonectomy, they remove the whole lung, like I explained before. I had that starred before, and I'm going to tell you, this is the only situation you're not going to need a chest tube for, because when they remove the whole lung, they tie off this bronchus right here. So there is no lung to expand and remove the whole lung, so there's no lung to worry about expanding. There's no air coming in here from the bronchus. This is just dead space not functioning with breathing, so there's no need to have a chest tube inserted after a pneumonectomy. Some thoracotomy incisions that you might see, they're different from a median sternotomy that you would see in open heart surgery, but they are on the side. They either go posterior lateral or anterior lateral. They're huge incisions, very, very painful. A little bit about VATS, because it's up and coming and has become the gold standard for performing chest surgery, and you may not have been exposed to it yet. It's sort of equivalent to having laparoscopic abdominal surgery. So when possible, they are trying to do this because it's minimally invasive and has less of a recovery time and less complications with it. Basically, 3 small incisions in the chest for the scope and other instruments. And these same openings are used later for when they place the chest tubes. Anytime they enter that pleural space for surgery, whether it be lung surgery or heart surgery, a tube has to be replaced after surgery in that pleural space to help equalize pressure from the atmosphere while healing. Now, the tubes don't have to be in more than a few days, but they need to be placed initially. You can do a wedge resection, lobectomy, or pneumonectomy in this way. Basically, they encapsulate the tissue and remove it through one of the holes. And it's as simple as that. A lot less pain also with this type of surgery. This is what it would typically look like. And then about the chest drainage system itself, it usually will sit on the floor beside the bed. Occasionally, some facilities like to hang it from the bottom of the bed like a Foley catheter, but most commonly you'll see it sitting on the floor beside the bed. There are 3 compartments that we're going to learn about, or it's called a 3-bottle system because in the old days, and this is before my time, believe it or not, they had what actually 3 bottles connected together. And then as technology improved, they got those 3 bottles condensed to one actual piece of equipment. So you're going to have a drainage compartment, a water seal compartment, and suction control. There's 2 types of systems. There's a water system and a dry system. And I'll explain a little bit more here in a minute. So this goes back to the old 3-bottle system. The drainage comes from the client. You have your water seal that prevents anything from going back into the client, and then your suction control. Believe it or not, this is what controls the suction, not the wall suction. So our drainage chamber 1, drainage chamber. Bottle 1, or the first chamber, is connected to the patient's chest tube, which is about 6 feet long. Fluid is measured hourly for basically the first 24 hours. If there's not a lot of fluid, you kind of play it by ear, and then it goes to every 4 hours. When this chamber is full, this drainage system, the whole thing, I'm backing up, can be replaced. If we were in class, I'd be able to show you how this is done. However, I'll try to find a video to post for you to show you how that's done. Chamber 2 is what we call our water seal chamber. So there's 2 centimeters of water in this chamber, and it's colored blue to make it easy to see. It prevents air from entering the pleural space, so air going back into that space. This is our one-way valve. And we have titling in this chamber, and this is considered normal. The water rise, or there's sometimes a little white ball in the chamber that will rise and fall with breathing. Absence of titling indicates obstruction, whether the tube's kinked, caught in a side rail, whatever. It's something that needs to be investigated, because if the obstruction's not released, the patient could develop Attention pneumothorax. Bubbling in this chamber. It indicates air drainage from the patient. NCLEX is going to ask you about bubbling. Excessive bubbling indicates an air leak. You should not have continuous excessive bubbling. What you should see, especially if it's placed for a pneumothorax, is intermittent bubbling. Maybe bubbling on expiration, bubbling when the chest tube is first placed, bubbling when the patient sneezes, coughs, or exhales. Those are all considered normal. Continuous excessive bubbling is not. Means we have an air leak. And then suction 3. It is suction chamber 3, I'm sorry. So this one is connected to wall suction. And this slide should be updated. This says connected to low continuous wall suction. That is for a wet system. Dry system, the suction on the wall is going to be a little bit higher. For a wet system, the amount of suction is determined by the water level in that chamber. The physician will order that. It's usually -15 to -20. In this chamber, that water will gently bubble. And that's why we use low continuous wall suction to get that gentle bubbling. If we turn our wall suction up too fast, we'll have vigorous, rapid bubbling. And then when that happens, it leads to evaporation of the water. And the suction level then becomes incorrect. If you would disconnect the system from suction, the wall suction, you would see that your water level has dropped and your patient's not on the ordered level of suction. I have a feeling this led to the decision for the facility that I work in to get rid of the wet systems and go to dry. This is a picture of our water sealed drainage system. This is our drainage collection where all the numbers are. We can write on this area, draw lines with a Sharpie and measure our drainage here. In fact, that is preferred that we draw a line and write the time. When it changes to a new day, we mark the day and then mark the times. This way, the physicians assistants, nurse practitioners can walk in, take a glance, and get an idea of the time frame of how much drainage has come out in the last day, 8 hours, whatever. This is our water seal chamber. See where this arrow is? That's where the water is filled to, and it's colored blue. In this small, thin channel is where you'll see water and that ball tidal up and down with respiration. And then this is where the water is filled to determine the suction level. We have 10, 15, 20. We fill this with the ordered level of suction and then hook this up to low continuous wall suction. A dry drainage system still has 3 bottles: drainage collection, water seal with our tidling chamber, but this is our suction control. We turn a dial to set the desired, ordered by the physician, level of suction. And then in this little window, how we know it's hooked to suction is there's an orange bellow that will expand and tell us it's hooked to suction. When it's off of suction, it collapses and disappears, and it cannot be seen. Nursing care of the patient with a chest tube. I will start another podcast and we will talk about this.